Now let us start talking about Mullerian anomalies. Now in the Mullerian anomalies, the Mullerian duct can just fail to grow altogether. That would result in Mullerian agenesis. I'm going to discuss this separately. Alright, as the name suggests, the Mullerian duct does not develop only. Alright, now the Mullerian duct was the duct from which the tubes and the uterus was arising, the entire internal genitalia, most of it was arising. So one thing can happen is Mullerian agenesis. The other thing that can happen is that there can be Mullerian ducts that they are formed fine, but what can happen is there can be various fusion defects. All right, there can be various fusion defects. They fail to fuse, they incompletely fuse, they fuse along the way, and some other anomalies which we are going to discuss. So we're going to talk about Mullerian agenesis and we're going to talk about fusion defects. All right, let's talk about Mullerian agenesis first. Now, Mullerian agenesis can be segmental. So, the agenesis is not complete, but it is in segments. So, maybe the tubes are present, but the uterus is not present, or the uterus is present and the tubes are not present, or vice versa, or cervix might just be absent. So, there can be segmental Mullerian agenesis as well. But what we are going to focus upon here is complete Mullerian agenesis. We are going to focus ourselves with complete Mullerian agenesis. So what happens when complete Mullerian agenesis? If you can appreciate in this figure, we'll see that there will be no uterus, there will be no tubes. Alright, so primarily in Mullerian agenesis, what will happen? The structures that are arising from the Mullerian ducts, they will not be there. So, there will be no uterus, there will be no cervix, there will be no vagina, okay. Instead of a proper vagina, what is going to be there is just a blind vaginal pouch. What is going to be there is just a blind vaginal pouch. Remember that part of the vagina which is endodermal, which comes from the urogenital sinus, that could be present. So there is no proper vagina. Instead, there is a blind vaginal pouch. Okay, this could be of varying depths. Okay, it could just be even a dimple, even a skin dimple. So instead there is a blind vaginal pouch, which is that part of the vagina that is coming from the urogenital sinus, All right. What else? The tubes. What about the tubes? The lateral 1/3 of the tube, that can be present as a remnant. What is important to understand is that the medial 2/3 of the tube is always absent. The medial 2/3 of the tube is always absent. Very, very important point to remember. Sometimes the lateral 1/3 of the tube can be present as a remnant, right? Now, what about the gonads? The gonads are fine. The gonads are ovaries. What about the gonads? The gonads are fine. The gonads are ovaries. Okay. And the karyotype of the female. What is the karyotype? The karyotype of the female is 46XX, that is normal. The karyotype is also normal. Now, another important thing to remember is that since the gonads are ovaries and these ovaries are normal, during the time of pubertal development, they will do their job. They will produce estrogen. The normal pubertal changes like the breast growth, the pubic hair development that happens because of the adrenarche, the adrenal androgens, they contribute to the pubic hair growth. Okay, we've discussed this when we were talking about puberty. So all other aspects of pubertal development are going to proceed normally. The height will also be normal, right? So the breasts are going to be normal, as we can see in this figure here. The breasts are going to be normal. The height is going to be normal, right? So the height is going to be normal. The pubic hair, which are actually coming from the adrenal gland androgens, that is because of the adrenal gland androgens. So the pubic hair development is also normal. So breast normal, height normal, and the pubic hair and the axillary hair, they are all normal in development. All right. So this is what is important to understand about Mullerian agenesis, that she is a female with karyotype 46XX with gonads as ovaries. Therefore, the pubertal development, the phenotypic expression of the pubertal development is all okay, but the problem is that she has no uterus to bleed. Alright, since she has no uterus to bleed, her problem is going to be identified when? It is going to be identified when, despite all the other aspects of puberty, she will fail to menstruate. Okay, so the problem with this woman is the problem is failure to menstruate. Failure to menstruate or amenorrhea, absence of menses, right? The other problem that is going to be there with her, can we do anything for this failure to menstruate? Do we create a uterus for her to bleed? No, it is not required. So this is something which will help us identify the woman, right? But we cannot help her menstruate, okay? The other problem that is very significant is coital difficulty. She has a blind vaginal pouch. She has a blind vaginal pouch. It might just be a dimple of skin, and that small vagina is going to create coital difficulty, and that is a problem that has to be dealt with. So for her coital difficulty, yes, we will help her out. The other problem that is there is going to happen is, of course, she has no uterus. So where can she keep the pregnancy? Nowhere. So infertility is her other problem. Okay. So for her coital difficulty, what are we going to do? We are going to go for vaginoplasty. Vaginoplasty if required. Why do I write if required? Because not all girls will require a vaginoplasty. Some girls could have a significant depth of the blind vaginal pouch. Then just using molds and dilators, Frank's dilators are used. Those are the names of the dilators. So just using dilators over a long duration of time can help maintain the or restore the length of the vagina. That is good enough for coital purposes. So people also try dilators rather than surgery first. But sometimes it is such a small blind vaginal pouch and maybe just a skin dimple, then of course vaginoplasty would be required. That means you create a vagina for them. So that is called as vaginoplasty. We have MEC Indo's vaginoplasty is one such procedure. So vaginoplasty can be done. The important point to remember is that this vaginoplasty is done when the woman decides to be sexually active. When the woman decides to be sexually active, because you create the vagina and then she doesn't use it for coitus. it doesn't help, right? So regular sexual activity after the creation of the vagina, that is after the vaginoplasty, is going to help maintain the vaginal depth. So vaginoplasty is done only when the woman decides to be sexually active. That may or may not coincide with marriage. So at around the time of marriage, when she is deciding to marry, that is the time when one needs to go for vaginoplasty. The other problem is infertility. What can we do about her infertility? Can we do anything about her infertility? Now, for her infertility, she does not have a uterus of her own. Okay, but she does have ovaries of her own. Her karyotype is 46XX. She is a normal female for all practical purposes, just the fact that the uterus is not there. So for infertility, we can use her own eggs. Okay, so she can go for IVF with surrogacy. She can borrow the womb. She can borrow the uterus that she doesn't have. So her own eggs and her partner's sperm can be used to create an embryo in the lab, that is IVF, and then the embryo can be implanted into a surrogate uterus. So pregnancy is also an option for them. Having a biological child is also an option for them because their ovaries are functional. All right, so this is important aspect about Mullerian agenesis, the problems and how can we deal with those problems. All right. Now, as we discussed previously in the development of the internal genitalia, that the development of the paramesonephric duct is closely aligned along the lines of development of the mesonephric duct, and the renal system and the genital system development happens in that space, and it is closely interlinked and related. So many of these Mullerian anomalies, they are associated with coincidental renal anomalies as well, or anomalies of the urinary tract as well, right? So similarly, Mullerian agenesis is also associated with other anomalies, and there is a syndrome, very, very important, called the MRKH syndrome. It stands for Mayer-Rokitansky Custer-Hauser syndrome. Okay, so this is the MRKH syndrome, Mayer-Rokitansky Custer-Hauser syndrome. It is a syndrome that is composed of Mullerian agenesis, okay, and along with that, renal agenesis. Horseshoe kidney can also be present, but Mullerian agenesis is more commonly associated with a renal agenesis rather than horseshoe kidney. That can also be there, but it is renal agenesis which is more common. And the other is hemivertebrae. Okay, so half of the vertebra develops. Okay, do not get confused. Some books write hemivertebrae, some books write scoliosis. Actually, scoliosis is just a phenotypic manifestation of hemivertebrae, right? So, hemivertebrae or scoliosis are actually meaning one and the same thing. Scoliosis is the phenotypic manifestation of a person who is going to have hemivertebrae. So, this is the association that is called as MRKH syndrome, has three important components. Okay, Mullerian agenesis, renal agenesis, and hemivertebrae or scoliosis. All right, so this finishes off the Mullerian agenesis part. Now we're going to talk about the fusion defects. So, revising Mullerian development, we understand that both the ducts have to fuse in the midline, right? Both the ducts have to fuse in the midline, right? Now, important thing to remember is that this fusion of both ducts happen at around 10 weeks. The other important point to remember is that the fusion begins in the center, okay? The fusion begins in the center, and from there it proceeds cranially and caudally, okay? Now, because developmentally this is so, what happens is any fusion defect is going to be more prominent at the fundus. Okay, what is the fundus? Fundus is that part of the uterus. Okay, this is the uterus, this is the tube. Okay, this part of the uterus is the fundus. Okay, the uppermost, topmost part is the fundus. Alright, so whenever any fusion defects are going to be there, they are more commonly going to be there in the fundus. So it is at the fundus where the fusion defects are more at the fundus, okay, rather than the rest of the uterus. Alright, now if we can appreciate here inside, we can see here that the cavity of the uterus has been formed how? Initially there were two tubes that fused together. So when they fused, the septum in between is there. So to form the cavity of the uterus, this septum needs to dissolve. Alright, so what happens is that if you can see here, what happens is that this septum starts to dissolve, and very, very importantly, remember that this septum is going to dissolve from below upwards. Okay, so this septum is going to dissolve from caudal to cranial, okay, caudal to cranial direction. So whenever this dissolution of the septum is going to be defective, the septum is going to persist where most commonly? In the upper part. In the upper part of the uterine cavity, the septum is going to persist. So another way you can remember is that the septum dissolves caudal to cranial from below upwards. Alright, and this dissolution of septum occurs or is completed around 18 weeks. Alright, so another way this question is asked is, when is the uterine cavity formed? The uterine cavity is formed at around 18 weeks. Okay, and the uterine cavity that is formed is, normally the uterine cavity is triangular on coronal section. The uterine cavity that is formed is triangular on coronal section. Okay, on coronal section means if the uterus is cut like this. Okay, so that is the coronal section, right? So it is triangular on coronal section. So other important point is, after the cavity is formed, the other thing that has to be formed in the uterus is the endometrium. So another important point to remember is that the endometrium differentiates by about 20 weeks. Okay, the endometrium differentiates by about 20 weeks, the same time that the vagina is canalizing. That is when the endometrium is also differentiating. Alright, so this is about the development of the Mullerian anomalies, how they proceed to develop. So one thing is that the fusion is defective, right, and the fusion defects are more again at the fundus, for the reason that the fusion of the two ducts occurs in the center first and then proceeds cranially and caudally. And the other anomaly that can result is that persistence of the septum can happen, and that is also more commonly in the upper part, okay, because the septum also dissolves from the caudal to the cranial end. Alright, so let us now see what kind of Mullerian anomalies as fusion defects can result. Alright, so in the mildest form, right, in the mildest form, what can happen is that there can be an arcuate uterus. As we can see in this picture, in the mildest form, there can be an arcuate uterus. An arcuate uterus is nothing but simply a flat-topped uterus. A flat-topped uterus, okay, or there might just be a slight depression. Okay, or there might just be a slight depression of the fundus. Okay, very slight depression of the fundus. Essentially the cavity is normal. So that is the mildest form of the anomaly, that is the arcuate uterus. Okay, just a small depression at the fundus or simply a flat topped uterus. Essentially the cavity is normal, so usually does not create any problem. All right, then the other anomaly can be a septate uterus. Okay, the other anomaly can be a septate uterus, and as we can see in this septate uterus, the fundus of the uterus, very important, the fundus of the uterus, in case of a septate uterus, the fundus is normal in septate uterus. So septate uterus means that there is persistent of this septum or partial dissolution of this septum. Now this septate uterus can be complete, a septa that is coming all the way, okay, into the internal os. Okay, so this is the septa that is persisting all the way. All right, or it could be incomplete or partial like this. Okay, what is important to appreciate in a septate uterus is that there is going to be two uterine cavities. There are going to be two uterine cavities. So the cavity is significantly distorted. So if you can see here, there can be two uterine cavities, but very importantly, the fundus is normal. So there are two uterine cavities, but essentially the fundus is normal. All right. Now the other kind of abnormality is a bicornuate uterus. Now what happens in a bicornuate uterus is that, as you can see here, in a bicornuate uterus there is a dip at the fundus. Bicornuate uterus results when there is incomplete fusion of the Mullerian ducts of the two sides. Okay, so the fusion proceeds fine in the bottom part of the fusion, all right, but in the upper part the fusion has not proceeded. So that leads to a bicornuate uterus. So this bicornuate uterus happens because of incomplete fusion. Okay, there is incomplete fusion, okay, of the Mullerian ducts. So when there is incomplete fusion of the Mullerian ducts, important to see that we have again two uterine cavities. All right, there is a dip at the fundus, two uterine cavities, there is a dip at the fundus. Okay, but there is a single body of the cervix. There is a single body of the cervix. The terms that is bicollis, unicollis, they are no longer used anymore. It is a bicornuate uterus with a single cervical body. So a bicornuate uterus has two uterine cavities, okay, two uterine cavities and a single cervix. So very important, bicornuate uterus has two uterine cavities and a single cervix. Septate uterus also has two uterine cavities, also has a single cervix, but the difference between the two is in their etiology, how they happen. Bicornuate uterus happens because of incomplete fusion of Mullerian ducts. Therefore, bicornuate uterus has a dip at the fundus, whereas septate uterus happens because of failure of dissolution of the septum. The fusion has been normal. That is why the fundus in case of a septate uterus is normal. Alright, so this is how the two are differentiated. From the inside, the two might look very similar, but it is on the outside that the difference lies. Alright, so one thing is this. Sometimes there can be complete failure. Of fusion of Mullerian ducts. Okay, when that happens, complete failure of fusion, then we will get two uteruses and 2 cervices. Okay, so when we get 2 uteruses and 2 cervices, as we can see here, and of course because there is complete failure of fusion, there is this dip at the fundus as well. This is called as didelphys uterus. This is called as didelphys uterus. All right, and then there can be another kind of anomaly when only one side of Mullerian duct develops and the other side development does not happen, or it happens in a very rudimentary form. That can give rise to an anomaly which is called as the Bicornuate uterus. That occurs when only one side duct develops. Okay, now when this happens, there can be a condition where only one side duct develops. All right, that leads to a single uterus with a single cervix, right? But then since there is only one Mullerian duct that is taking part in this development of uterus and cervix, this the capacity of this uterus is much lesser as compared to a normal uterus. All right, then there could be a rudimentary horn. So this one has no rudimentary horn. There can be a rudimentary horn as well. Okay, there can be a rudimentary horn. So there can be a rudimentary horn. Okay, this rudimentary horn can have no cavity, or it could have a cavity that is communicating with the rest, or it could have a cavity but that is not communicating with the rest. Okay, and so there can be different kinds of anomalies. All right, so we have understood what is the basis of these anomalies. Let me just summarize them for you as well.